It's a pleasure for me to be here. And before I get started speaking today, I just want to spend about a minute to pay tribute to Paul Selecki. And thank you very much, Paul, for being the godfather and the father of our palliative care program here at Hoag. And it was your inspiration as well as your mentorship that brought me here to Hoag, where I get to spread my wing and be the best that I can be. I know that today is going to be one of your last I don't know how to say this, but your introduction, you're introducing me today is a real honor, and I know you're getting ready to retire, and so I truly appreciate you and what you do for us in our CARES program and your vision of bringing palliative medicine here to Hoag. So thank you very much, Paul. The topic that I'm going to be speaking on today is on end-of-life options and the gift of palliative care. When I use the word gift of palliative care, I don't see myself as a gift, but I've been giving skill sets to bring palliative care to our community to serve those who are seriously ill. So Paul did mention to us several of the objectives that we're going to be speaking on today. So without further ado, I'm just going to jump straight in to talk about what palliative care is. And I've been up here several times, and it's just a quick reminder of what we do. Well, palliative medicine is a specialized medical care for people with serious illness at any age and any stages in their disease. The work that we do is to reduce physical symptoms as well as the emotional, psychological, and spiritual stress for the patients and their family. It's about a whole person approach. And the objective behind palliative medicine is not about hastening people's death, nor are we here to prolong the dying process. We seek not to eliminate the person, but rather the pain and the suffering that afflict the person. In another word, we're here to relieve the suffering, not the sufferer. So palliative care oftentimes get misconstrued and misunderstood, and that patient has to give up on treatments in order to receive this type of treatment, but need to understand that palliative medicine is delivered along with curative treatments. We have a clinic here at Hoag on the third floor where I get the opportunity to practice a skill set of palliative medicine, not only on the inpatient, but also on the outpatient arena, caring for patients who are still going through their chemotherapy, radiation, their treatments for cardiology, and on various treatments to help prolong their life. So we're there to provide symptom support and as well as the emotional support for patients and their family. And part of what we do also is to ensure that whatever we do to the patient matches their treatment preferences of the medical care provided. And yes, you look at this form, you recognize that pink form over there, the PULSE form that we discussed many times here before, in the California Advanced Directive. It's about how to give patients back the control of how they want to live until they die of a natural death. And the beauty of palliative care is not just a one-man, one-woman show where the doctor leads, but it's about the whole team approach. And I'm proud to be part of a wonderful CARES team here at Hoag, where we have wonderful social workers that deal with the psychosocial, emotional for patients hospitalized as well as in the outpatient arena. We have a wonderful clinical nurse specialist who works together with our team along with the pastoral care to deal with the spiritual issues. Here's something that we typically see traditionally when we have palliative medicine and hospice and how does all fit in. You know, how it worked in the past and how it's still misunderstood today is that, you know, on one day when patient is presented with a serious condition and as their disease progresses toward death, you know, we spend most of our time providing treatments with curative intent, hopefully to slow down the disease or perhaps cure the patient. And all of a sudden, if it fails the next day, gee, you're going on hospice. So this is a very traumatic transition for patients and family as we see this. And so palliative medicine get lumped in there. But the way in which we see palliative medicine as this whole transition, as this whole coordination that's taking place today, is that when patients presented with a serious illness, as physicians and as clinicians, we focus on the disease-modifying therapy. How do we modify the treatment to meet the needs of the patient? And in the beginning of the illness, most of our efforts, as you can see here, will be focused on modifying the disease. But yet at the same time, we cannot forget about providing symptom control and supportive care. In the beginning, there may not be a whole lot of symptom control and supportive care, but as the disease progresses, you'll see that modifying therapy becomes less and supportive care is increased. And this portion of supportive care is called palliative care. So where does hospice fit into all this? Well, hospice is part of palliative care, but as you can see here, under hospice, it's more toward the end of life, and as defined by Medicare as someone having a prognosis of less than 6 months if the illness follows its normal course. And as you look at the hospice pieces, yes, they do focus a lot on symptom control and supportive care, but there's not a whole lot of focus on the disease-modifying treatments. So hospice is focused mainly on high touch, high care, and low tech, whereas palliative medicine comprises of high tech, high touch, and caring for the patient all the way through the end of their life through bereavement. So you see hospice as part of the whole continuum, and I think this is an easy way to explain what it is that we do. Part of what we do is to deal with people's suffering. Suffering is multi-levels. There's the physical, the emotional, the psychological, as well as the spiritual. So suffering can be promulgated by uncontrolled physical symptoms. There's also the social isolation that's associated with the disease process. People are alone emotionally, they're depressed. Psychologically, they're not where they want to be. There's this loss of self-image. How is this happening to me? How do I relate to others? And there's this thing called the existential angst. Well, if there is a God, if I believe in God, why is this happening to me? Why does bad things happen to good people? So we often deal with these suffering, the total person. Part of what we do, and what we do is to provide that hope in the midst of the suffering, is to attend to their physical needs as well as managing their physical symptoms as well as their psychological, to improve their mood, provide a sense of hope, and to improve their quality of life. And help people and their family understand that life serves as has a purpose, and it holds enough meaning for the continuum of the existence. I'd like to share with you a story of a gentleman, CP, whom I had the privilege of caring for. Mr. CP was a 59-year-old gentleman who spent 22 years of his life fighting or had Lou Gehrig's disease. In the last 2 years of his life, he became dependent on G-tube feeding and had a tracheostomy to help him breathe. He couldn't communicate to us toward the end of his life, and the only way he was able to communicate is utilizing that special communication board where his eyes are set in such a way that when he would look, it looks like a keyboard where he would be looking at a letter, and that letter would type up, and so that's how he would communicate with his wife and his children. Because at this time, he hardly can mumble any words, and you can barely understand. And what is also sad that his son was also found to have the same genetic disposition. So he's watching his father living and suffering with this disease. And so you can understand the suffering that he's undergoing and how the burden on his children. So I asked him, tell me what you're going through. Can you teach me? Teach me on how you live. Teach me on how you deal with your serious illness. And what he did, he started blinking his eyes, looking at the computer, and this is what it came out. It says, abundant life can be accomplished through suffering. In the midst of the struggle, we discover the depth of God's love. So from the spiritual angst, the emotional, the psychological, and everything else, this man had it all together. He embraced his illness with much dignity. And I asked him to take a copy of this, because the way that we care for our patients, we always talk about as doctors. Yes, we learn from each other as physicians and nurses. We also learn from textbooks and journals, but our best teachers are our patients. And this is what CP taught me, and I want to share that with you. So let's talk about how we Americans face the end of life. As Americans, we are very independent. We like to control our lives. And, life is great, but there's not a lot of time to think about death or the final stage of life. So as a result, when it does come up, these heart-wrenching decisions, most people are very unprepared. And I can tell you every single day that we are here at Hoag, my team and I work and care for families and patients who are trying to make sense of all of this. Well, the reality, as you can see here, the mortality rate has not changed. And the death rate still holds steady at 100%. So no one of us will get out of this world alive, even though, yes, Californians who think that, that doesn't pertain to me. We live in a death-denying culture, with that said. We're unprepared and oftentimes are fearful about what this process may bring. So we have a lot of fantasies what death and dying may look like. I was at a presentation this past Tuesday night when we were giving a presentation to the community, and people in the crowd were imagining what death would be like. They think people would be laying there in severe pain, diarrhea, laying their poop in the urine, and death becomes so unattainable or so uncomfortable. And I shared with them that death is not that scary. For most people, it's a peaceful sleep. Except for patients with cancer, they may need some assistance with pain medications and the use of opioids to help relieve their pain, their dyspnea. People don't necessarily have diarrhea at the end of life. They tend to get constipated. So this is really somewhat an unrealistic portrayal for people writhing in pain, screaming, and just like what you may see in TVs. And most of us have not seen what a death looks like. So we imagine this process of great suffering and gruesome process. And so this uncertainty creates a strong desire to have some sort of control. And so this rule, this law on assisted suicide becomes like, oh, it's a nice option. At least it provides control. If not a control, maybe a peace of mind. At least I have some sort of, I have some comfort there. The common fears that people often have are the following. They don't want to be a burden on their family. 40% of Americans say, look, it's my turn. I don't want to be a burden on anyone. I don't want to lose the loss of my dignity. I don't want to start pooping in my pants and having someone else clean after me. I don't want people to do that. And I don't want to be like that. And they're afraid of their inability to do things that they once enjoyed. So much of the assisted suicide campaign, as we see, is based around fear. And it's true fears indeed. And these are the fears. Most of us have thoughts, most of us in this room have probably thought about what the end of our life may be. And so I'm sure there's fears. Some people don't fear death. They just don't want to be there when it happens. And so controlling is part of this key part of the legislation's appeal. So why the suicide debate? Well, it is, when we talk about assisted suicide, it's a very, very sentimental subject. And we have people from both sides of the board who are very, very passionate, who will stand up and say, yes, people have the right. And there are others who say, let's look at the case and look at the big picture here. Because we realize sometimes emotions will lead us astray. And sometimes our emotions, as we understand it, sometimes will, give us that mode in which, we're not thinking things through clearly as best that we could during that moment. And this whole suicide debate is based around autonomy, the freedom to choose what to do with my body. It's my body, it's my choice. How often have we heard that? And also, on top of autonomy, we have all these life miracle, modern technology, this life-prolonging technology. There's always got another treatment, another pill for the ills. And also, we heard about the highly publicized case of Brittany Maynard a young woman with glioblastoma who was a resident here in Irvine, moved to San Francisco, and later in the last months and last year of her life moved to Oregon to take advantage of the suicide bill that was legal in Oregon. So California wanted to be like Oregon. So in January 2015, just last year, Senate Bill 128, called the California End of Life Act, emulated the Oregon's Assisted Suicide Act. What does that mean? It just basically allows physicians in California to prescribe life-ending barbiturates to help people who are terminally ill to end their life. And the barbiturates they use up there is secobarbital. I mean, Seconal. I used to prescribe Seconal for a few of my patients to help them sleep. I mean, these are people who just couldn't sleep well, and sometimes we give a low dose of maybe 50 to 100 milligrams. The dose that's required for Seconal, we're looking at maybe 1,000 to 2,000 milligrams. A lot of medications to take. So the idea behind this is let's help our patients die. So how do we define terminal? So Oregon defines terminal as people with having irreversible and incurable disease that has been medically confirmed and will, within reasonable medical judgment, that the person will die in less than 6 months. It sounds very much like hospice. People who's incurable, you got a prognosis of less than 6 months, here's an option for you. However, at that time, California, the debate went on, which that bill was defeated. So the pro-assisted suicide folks found a way. They resurrected the bill. They changed it. Instead of Senate Bill 128, now they call it Assembly Bill X215. And they snuck it through by using this whole Assembly Health Committee. This is the regular way in which our bill is passed here in California, but they found a loophole, so they put it under the special session on healthcare financing. And this healthcare financing has been talking about how do we fund the poor in our state. And it passed. And it went to Governor Brown, and he signed this bill into law. So the question then is, when does this act become law? When does it take effect? It takes effect 90 days after this special health committee. And so let's talk a little bit what this ABX 215 means. It allows the dying patients to end their life through lethal dose of medications, as long as the medication has to be self-administered. The patient has to take it themselves. The patient is deemed competent by their attending physician. And you need 2 physicians, just like hospice. You get the primary and another physician to confirm that the patient has less than or equal to 6 months left to live. And patient has to reaffirm their consent within 48 hours prior to taking the lethal dose of the medication. So this is a really broad view of it, and you want to look at this even, so this law goes into effect on June 9, 2016. What I want to say about the California End of Life Option Acts is that, most ethicists will tell you that what is law is not always ethical, and what is ethical isn't always the law. And some will even say unjust laws are not laws at all. So what does it mean for us as physicians, as healthcare providers, and us in the community? From my stance, the passage of the End of Life Option Act, or this physician-assisted suicide, doesn't imply that we've resolved the debate on this aid in dying, nor should it define our moral stance. So what is the provision of the law for patients and doctor? I'm going to quickly go through this. It's really minuscule, but if you're interested in these little things, I'll go quickly through that. Patient has to be terminally ill, likely to die in 6 months. They have to have 3 requests to the attending physicians, twice orally, at least 15 days apart, and once in writing, 2 witnesses to all requests. So you have to really check boxes, right? Here's the check boxes. Go through the check box. Request of this assisted suicide pills cannot be made by the patient's spouse, parent, legal representative, power of attorney, conservative surrogate. And there has to be a signed attestation within 48 hours of ingesting the drug. So you have a form that says, yes, I took the form, I took the pills. And the patient says, I ingested the drug on my own. The physician, on the other hand, must confirm that the person has the mental capacity to make decisions. So it's not just here, I'm sad, I'm just here, give me a pill, but we have to check whether or not the patient understands the benefit, the burden, look at the consequences of their action. We also need to discuss the diagnosis, prognosis, as well as the alternatives to their request. Let's discuss the risk and probable results of taking the drug. Nausea usually will be the first one, so and patients are typically die 15 to 30 minutes after ingesting the drug. Tell the patient that she can obtain the drug but not take the drugs and can withdraw the request. Basically, here's a prescription, go to your pharmacy, you can buy it, but you really don't have to take what it's there for you in case you need it, and you can always bow out. You need physician also, got to refer to a consulting physician for confirmation of diagnosis. And once the confirmation is received from the consulting physician, the drugs can be prescribed. And so there's a bunch of documents that you have to fill out. So these are the safeguards to protect, to make sure that people are utilizing it correctly. But the duty of the physician is to alleviate suffering. That's what we do. We benefit the sick, we safeguard human life, and we unburden people's fears. So when we talk about medical ethics and it comes to healthcare decisions, there are 4 terms that usually pop up. Beneficence, it's doing what is good. We use our knowledge, we use our skills to help and to heal. The second part of medical ethics is non-maleficence. Let's not do harm. We sometimes will have to put some risk in there. The patient may have to go through discomfort. Let's say when we inflict pain on patients, when we take them to surgery, the necessary risk and discomfort is great so that we can remove that tumor or that rupture appendix. When we give patients chemotherapy, it's a trade-off. Yes, maybe perhaps when we give you this treatment, it'll extend your life. Maybe you just have to live with the nausea, the vomiting, and maybe you lose your hair. But hopefully we'll get your cancer under control. This concept of justice is, you expect the same quality of care regardless of your ability to pay or so. And the last piece is autonomy. And I'm going to talk a little bit more about autonomy here. There's a big difference between foregoing burdensome treatments at the end of life and actively killing. And what do I mean by that? So as a patient, and it comes to autonomy, patients have the right to their body. They have the right to refuse life-sustaining treatment. People can say, I don't want that tube. I don't want an artificial tube feeding when I'm at the end of my life. When I have advanced dementia and I can no longer swallow, I don't want that tube. If I have a massive stroke, I don't want that G-tube. People have the right. People also have the right to say, hey, after a few days on the ventilator, you cannot wean me off of the ventilator in the ICU, and we're talking about tracheostomy and putting me in warehouse me in a long-term acute care that I can lay there and receive treatment, and that's how I want to live. That's not how I really want to live. So they have the right to say no to that. That's what the advance directive, what the POLS are there for. They have the right to proportionate palliation, even if death is hastened as a side effect. And when we talk about proportionate palliation, we're talking about the person has a pain that requires 1 or 2 milligrams an hour of morphine for their pain or their discomfort. Proportionate means we give somewhere between 1 to 3 milligrams, just enough to keep them comfortable. We're not talking about giving patients 10 or 50 to 100 milligrams an hour. That's not proportionate. We give the right dose, the right amount. And we're not here to hasten the person's death, but there are certain things that we do that in the intention of relieving pain and suffering, the person's life may be shortened, but the intention is never meant to put these people out of their misery, and let's just end this right now. So people have the rights to that. They also have the right to voluntarily stop eating and drinking. You can do that. And people can also have the right to end their life by all manners of methods that do not involve physicians. This is why the word physician-assisted suicide doesn't ring very well. It doesn't go along well with what we do as physicians. Why do I say that? Well, there are 3 fundamental principles I'm going to touch upon First is this intrinsic dignity of the disabled and the vulnerable. The second is the new freedom that arise can, for one group, cannot provide or cannot putting on an owner's burden on another group, and the responsibility for culture of life and dignity. So let's talk about dignity and intrinsic dignity. The intrinsic dignity is what our Constitution is based on here in the United States. Intrinsic dignity is we have the right, we have this inherent quality human life which is inalienable, and it doesn't necessarily bestowed on us just because of our social status, what we do in society, how much money we make, or whether or not we're a famous person or not. So as a human person, our intrinsic dignity, it's worthy of great respect. It must be free from exploitation, manipulation, and slavery. So in terms of manipulation, I use the word deceptions and desensitization of language when we talk about, look, physician-assisted suicide sounds really nasty, it sounds bad. Maybe we can change it to something else that's less negative, less distasteful, it sounds this connotation, let's change it to something else. So we often hear the word substituted for physician-assisted suicide as physician aid in dying, death with dignity, and the right to die. So physician aid in dying is still physician-assisted suicide. Giving a person a lethal drug to end their life is not really an extension of good care of hospice or palliative medicine. It's just bad medicine. What about death with dignity? What are we saying with dignity here? It implies that the people who are sick, frail, or physically dependent people aren't dignified. We talk about losing our ability to control our bowels, can't do anything, and we allow other people to help us. It just basically, we understand that people who are disabled, people who have cerebral palsy, people with Down syndromes, people who's at the end of their life can be cared in ways that allow them to feel respected, worthy, and valued. What about the right to die? We mentioned a little bit about this. The right to die is, look, there's no such thing in our Constitution as the right to die, but rather there is a constitutional right to refuse life-prolonging treatment. And I want to use the word life-prolonging treatment. I can often see that as non-beneficial treatments, death-prolonging, or even we call it organ-sustaining. So there's a difference between allowing to die of your illness versus having a physician intentionally end your life. So what about this extrinsic right? We talk about intrinsic, here's the extrinsic. This is something that's bestowed upon us. So with this law, it will certainly benefit a selective class of people. Usually it's upper middle class, white, male, who desire the right to control the circumstances of their death. Yes, we see the benefit, but the harms, have we looked through the harms? What does it mean? What about the most vulnerable people in our society? How about the depressed? As doctors, we focus on caring for people and dealing with their depression. What about people who are sick and disabled and the older adults? These are the vulnerable members in our society. What about the socially and economic marginalized? You can't afford their care anymore. How about the suggestible, people who have psych illness and they have a propensity to commit suicide and they see that this is being glorified? What about those folks? What is this? Picture of the San Francisco, the Golden Gate Bridge. What is it known for? Beauty? It is beautiful, but it's also, what does it represent? It's the number one, it's a top suicide spot in the United States, secondary to some place in China. So this Golden Gate Bridge is about 25-story high, and it takes about 4 seconds when someone decided to jump off the bridge into the water. It's been around, this bridge has been around, I believe, in about 70 years. And I just did some math last night. Based on what we know, it seems like every other week we know that someone is basically on average jumped off the bridge and died, as far as we know. Sometimes we can't even find their body. That's a long way down, as you know, with the water tension. Jumping from that height of 25 stories into water, it's like landing on concrete. We go splat. But believe it or not, there are a handful of people who did survive the jump. A handful of people who survived. And so there are a bunch of reporters, they're real excited. Say, hey, let's talk about this. How did you survive? Even though you got broken ribs, fractured your back, you're handicapped. And they asked him, so what was going through your mind when you jumped off that bridge? And the reply oftentimes is, in that 4 seconds of free falling, I realized that all the problems in my life can be solved, except for the fact that I just jumped. So what do we see here? Temporary depression can make life seem permanently intolerable. And an option can appear to be the only option. What about societal pressure and coercion? We'll talk about quality of life. We hear this oftentimes in the world of palliative medicine that we live in and what we do as physicians is, let's focus on quality of life. But it sounds like quality of life becomes more important than life itself. Death is better than living with a disability. I also want to talk about the right. One person's options becomes another person's duty. And this is the slippery slope that folks, we often don't think about. Maybe it happens in other countries, maybe it doesn't happen here at all in the United States because we're different than Europe. What we see, what is legal then becomes socially acceptable, and what is socially acceptable then becomes a moral obligation. We see this, if it's legal, it must be okay, isn't it? If it's socially acceptable, then maybe, and it becomes a moral obligation. So what we see here in Europe is that the right to die, the movement that was happening there, became the duty to die. We see this in Holland, the Netherlands, Belgium, and the culture of suicide. What we see is that it started out with people who are terminally ill, people who may have a prognosis of 6 months that stretched to 12 months, and now it's stretching to those who are, I'm tired of living. Recently, there was a case this past year. There was a gentleman who asked to be euthanized because he had mental anguish. He was a transsexual. He had his sex changed, didn't like how he looked. So he asked the doctor, said, end my life. And the doctor complied. And so this tired of living not only for those folks, but also for prisoners. Hey, I'm living here in prison, I don't want to live like this anymore. And we had a case of a husband and wife who are increasingly weak and debilitated, and they're saying, I don't want to go to a nursing home, just end my life. Well, those are voluntary euthanasia. Hey, kill me. But there's this thing also called involuntary euthanasia, where physicians, clinicians, doctors in the country, where they would deem that life isn't worth living. So they admitted, even though it's against the law, but they have admitted that, yeah, I give more medications than I should to just ease that person's suffering. They did that in children. And there's also about, let's make it easy for people. We hear about physicians making house calls to care for these patients. Well, there are also these mobile suicide units where we just come, talk to you, give you a shot, and then half an hour or 15 minutes later, we'll just carry you away. So here are the cases that's reported in Belgium. It goes up every single year. Let's talk about safeguards. I share with you that one slide where the duty of the patients, the duty of the physicians, and all these things. Yeah, let's put safeguards in place. And you can look at all that, all the check boxes. It's impossible to ensure that patients are acting autonomously. Are people really taken, or are they forced? We don't know that. Do people really have the capacity to make decisions and be free from coercion? I'm not sure. And as we learned from Oregon and Washington, and for physicians who practice up there, and even though they have these reports, You hear from the physician say, no, there's a lot of secrecy. There's two different reports, what you see and what you're not supposed to see. And we can understand, too, with a law, the permeability of the law and the twist of logic. We can change anything to make it mean whatever we want it to mean. And this safeguard really is not for the patient, but the safeguard is for the physicians. We are protected by law to do this. So is it safeguard for the physicians or is it safeguard for the patient? And I would say it's for us doctors. Here's something that's predictable and inevitable. You know, this is the organ-assisted dying law that I said earlier. It's, you know, it's for people with a terminal disease who likely will die in 6 months. Well, there's a House Bill 3337 Oregon that's sitting right now where it's debated to expand the assisted suicide law and modify the definition of what is terminal. Let's push it back to 12 months. I can tell you as a palliative and a hospice physician, it's hard enough to make a prognostication. Patient's going to live for a few weeks or a few months. There, you know, we just make a guess. 3 months or 6 months, it's a little bit more difficult. But stretching it to a whole year, I would say if your prognosis is 12 months or less, let's have a pulse conversation. Let's talk about advanced care planning. Let's talk about that. But you're going to move this to say, hey, looks like you have 12 months left. Let's do it while we can. So physician-assisted suicide for some is, look, it's really an act of compassion. It eliminates the suffering. And I beg to differ as a physician. I really believe it's misguided compassion. It eliminates the person who's suffering rather than we're trying to do our best to eliminate the pain and the suffering. And of course, it leaves great suffering for those behind. I love the word care. I love the team. I love what we do in palliative care. I love the word cares that define what we do in palliative medicine and what we're doing here at Hoag. Always care, never kill. So I really think that palliative and hospice care offer compassionate and medically sound alternatives to assisted suicide. I do this because what my patients have taught me and what I've done over the years. And it's really exciting to see how palliative care is beginning to flourish, is beginning to grow. It's grown in recent years. More doctors and nurses, social workers are being trained to provide it. And even the state law are mandating or at least require Medi-Cal managed care to provide access to palliative care programs. Where the funding comes from, we're not sure, but the law is there. We just have to get a genie and rub it, and then maybe we have more money in the bank. But however, if gaps remain, even though palliative care is expanding, in California, there's about there's almost 60 counties, 58 I believe. There are 22 counties lack access to community-based palliative care. And a 19 county lacks access to an inpatient palliative care program. Still, we're growing, but still a need. And there's some other things that we need to be aware that, while 90% of doctors should have end-of-life discussion with their patients, and the reality is 17%. This is based upon the Kaiser Health Foundation study done recently. So this is really a wake-up call to clinicians, to physicians, all of us who are in the medical field, that people are terrified. People are really scared what's going to end up. And so we need to be educated. We need to understand what it implies and to provide hope and to address people's fear. And we know that people forego end-of-life discussions in the absence of palliative care programs. So if there's no palliative care program, there's no need for advanced care planning. There's really no need to discuss it because I really don't have time or it's just too difficult on me as a physician. But the beauty of this as physicians is we learn to do this. We can bill to have a conversation. And this was a new law that was passed last year and it became effective January 1st. Whereas physicians, when we have an advanced care planning with our patient and family, and actually, patients don't even have to be there. If we speak to the caregiver or the durable power attorney on the advanced care planning while the patient may be sick and may not have their mentation intact, you can bill for that visit. So before I end, there are 3 takeaway message. As physicians, we have the obligation to openly discuss patients' concerns, the family's unmet needs, feelings, and desires about the dying process. We are here as doctors. We're here to provide, unburden people's fears. When people ask for assisted suicide, it's not like, oh, really? Here's a prescription. Here you go. But let's talk about what are your fears? What are your concerns? What are your hopes? Let's sit down and talk to them. Let's tease it out. If life is short, what is most important to you? And respond to them in a potent therapeutic intervention. We know that when concerns are effectively addressed, most patients who initially consider obtaining a lethal dose of medication do not persist with their request, and they became grateful. I share this with you as well as based upon my studies, my experience. And as you know, or maybe some of you do not know, that we do have a palliative medicine fellowship here at Hoag. We just recently graduated our first fellow in January. She had 15 or 16 offers all across the country. She turned down Stanford. She opted to go to Scripps, San Diego, so you can't go wrong in San Diego. We currently have 2 physicians who are finishing up their fellowship as well. One is an emergency physician. He finished his 3 years at UC Irvine, and he's finished up his fellowship in palliative medicine. He isn't going to do palliative medicine full time, but he's going to incorporate palliative medicine in his emergency medicine training. And we also will be graduating an internist, internal medicine resident who finished 3 years at Harbor UCLA, and these folks are just doing great. Next year, we have 2 more fellows, one of whom is another emergency physician. He's been in practice now for 8 years, chief resident at UCLA when he was here. Excited to have him here. He doesn't plan to do palliative medicine full time, but he's going to integrate that in the emergency department and grow programs across the country. We also will have a cardiologist trained as an electrophysiologist from the Mayo Clinic. I'm excited because I'm excited to see physicians from other fields are having interest about palliative care to meet the needs. And I really feel that, to become leaders, we have to become teachers. And teachers here aren't necessary. We teach with our words, but we teach with our actions. So with that, this is what the gift of palliative care. The gift of palliative care is to give what's given to us and give it back to our families and our patients in our community who have these fears. Thank you very much. Yes, please. I know there has to be an opposer say, hey, the patient's got the right. It's okay, let's talk about it. Yes. Yes, the question is, what about insurance company? Will they deny payment? Well, historically in the state of Oregon, there was a woman, I don't know her name, she had metastatic cancer. And cancer was in remission, but it came back. Her HMO in Oregon decided that, no, we're not going to pay for your treatments because it's too expensive, but we'll be more than happy to pay for the prescription for assisted suicide. What we're seeing here in California, I'm looking at a bill that's being put forward by pushing the prescriptions, the pills on taxpayers. So people who request to have their life terminated, the taxpayer will be paying for that prescription. I also heard recently, a couple of days ago, just speaking to some leadership up in Sacramento, the medication secobarbital I mentioned was, don't quote me on this per se, but I'm hearing this as hearsay from a very trustworthy team, is that the pharmaceutical company just bought secobarbital. And for those who are in practice, yeah, we used to prescribe these. It costs 10, 15, 20 cents, pretty inexpensive. But it's a business. So for a prescription for about 100 tablets, you're looking at several $1,000s. Yes. Yes. Great question. The question is, what about if I have life insurance and I take this pill and I end up dying, and will my life insurance pay my family? And the answer is, it depends on what is said on the death certificate. So what's been done up in Oregon and Washington is the patient may have dementia or Parkinson's or cancer, and if they took the pill to end their life, what's stated on the death certificate is the cancer, not that the person took the lethal pills. Did that answer your question? I am not sure. I mean, this is, we mentioned about the shroud of things that things are still unfolding, even though I try to stay on top of it. I don't have the answer for you, but it's a great question. And we talk about the safeguards. I just don't know. We're still learning. Yes? Oh, great question. Do we have the right as physicians to deny the person's request? As a physician, yes, you can. As the hospital system here at Hoag, we are taking a stance of not doing it. So this is going through our ethics committee, and the final language is still is in the finalization. So here at Hoag, it's not going to be done. The question then, where do these people go? So up in the legislation, Sacramento, there's another group that say, hey, we'll get the taxpayer to cover this 800 number, and maybe we'll use compassion in choices. These are the people that used to promote assisted suicide. They're the Hemlock Society, and so maybe let them do it. Still a lot of debates. So as a physician, if it's against your ethics and your morality, you can always say, no, I cannot participate in that. But again, just because you don't participate in that, it doesn't mean you throw your patient out. We need to sit down and ask, tell me about your fears. How can I help you? One of the things I didn't finish my story about our fellowship, because the fellowship came out of the opportunity that I had in caring for a patient who came to my clinic and asked, help me die. And I spent about 2.5 hours with him, with his wife. And I'll make the story really short. And I helped him through, and he died naturally. His fear was, I'm having cancer, and my pain is, I've been living with this pain, and this is not worth living. And I promise I will do everything I can to help relieve your pain. I also told him, look, your life is not mine to give, nor is it mine to take away, but I will do everything I can to help you through your journey. I give him some tasks. Here are the 4 tasks I want you to do. Forgiveness, to say, ask for forgiveness and to grant forgiveness. The second thing is say thank you, say I love you, and be able to say goodbye to your family. And this is a man who's been married about 3 times with kids from various marriages, and his current wife is with him, is just recent. He has never made peace with his children. He utilized that time to make peace. And then helping him through his pain and his journey, I cared for this man, and he finally succumbed to his illness. He called me, his wife called me on a Sunday. So I said, let me come out to see him. And when I saw him, I said, I promise you I will be here with you. I will not abandon you. And in his stupor state, he opened his eyes and he muttered a few things, and the family said, yeah, he said, thank you, Dr. Nguyen. Lo and behold, about 3 months later, I got this call from a woman. She said, Dr. Nguyen, thank you so much for caring for my friend. I just want to let you know I just sent you a little check to your program to support you in what you do. Continue the great work that you do, because there will be more money coming along. And I said, ooh, I can't wait. I'd love to get more money for the program. And she says, oh, what are you planning to do with the money? I said, I want to do a fellowship. And she asked me how much. I told her, a 6-figure. And she said, don't worry about it. I just sent you a check in that amount. And then she also wrote me another check for this next year's class. So I'm just grateful to be here, and I'm grateful for the patients, and I get to be the witness of caring for people and the healing that takes place when there's no cure. There's a lot of fears out there, but there's a lot of hope. And so, thank you for the applaud. I appreciate that. And Paul, thank you for all you do. I appreciate you and your lovely wife being with us today.